Good evening to all of you students. How are you all doing? I hope you're all great. So am I. And today we are set to enter into the last evening of discussing medicine with you. It has been a wonderful last week. Yes, Sagar Lakhani, I am back with my last ride. I don't know how far is the title of Guru fair with me, because I am myself an amateur. I am myself a disciple and I am still, learning medicine. No age is enough to learn medicine. Alright, so how are you all doing? And I hope all of you have revised medicine nicely till whatever we have discussed. I have posted threads each day on the Facebook club. I have tried to answer as much queries as possible. Most queries are unanswered are actually intentionally unanswered because they have already been previously answered twice or thrice before. So you guys have not taken the pains to just look above in the comment section and look for those queries again. Okay. Alright, so it has been a very, very, thrilling and an emotional journey for me as well, discussing medicine with you. And let's start our usual day with the very mandatory, the very compulsory, how's the Josh? Hi sir, how's the Josh? Superbly high sir, how's the Josh? Never gonna die, sir. That's the way, students. That's the way. And with this high Josh, we are going to start today's nephrology class. But before we begin, just a daily dose of motivation that there is no elevator to success. You have to take the stairs. So, if somebody says, sir, I have only a few days left, I have not studied till now, please tell me how to crack the PG entrance exam. I get many such messages. Sir, I had this and that personal problem. I was tired in internship and whatnot. Sir, I have not been able to study. How will I do so? Let me tell you, there is no elevator. There is no shortcut. You have to take the stairs. You have to take the hard way out. I listen to many toppers interviews, and some of those toppers in their humility, they tend to say that they didn't work as hard enough. But let me tell you, they are lying to you. Do not get misguided by their humility. They have worked their asses off. Nobody becomes a topper without working very, very hard. So there is no shortcut to success. There is no shortcut to hard work. And very importantly, I want to help you inculcate the very important virtue of sacrifice. Let me tell you, if you do not sacrifice for what you want becomes the sacrifice. Please understand that, sacrifice is a very important virtue. If you sacrifice something that is very dear to you, that is very, very important to you, which is for a bigger good or for a bigger goal, and you give it to the universe with all your purity, let me tell you, the universe will get back to you and it will repay for your hard works. Though you should not do it, you should not sacrifice something just for the fruit of it. Because if you remember, yesterday we had discussed the verse 27 of the second chapter of Bhagavad Gita, which said, Karmanne vadikaraste ma phaleshu kadachana ma karma phala hetur bhurmate karmot swakarmani. We had discussed that. So we should not do entirely for the fruit of it. But yes, please do sacrifice. In today's context, do sacrifice your things, your social media, your WhatsApping, your YouTubing, your Amazon priming, your series, all those the web series that you hear consistently about in your surroundings. You do feel left out at times, but do sacrifice them. Why? Because sacrifice now will yield you a big good for the future. It is that दूर के फायदे के लिए पास का नुकसान. Some people might be thinking, sir, ye pass ka nuksan is not ending only, sir. In class 9, we were told, just crack the board exam, your life is set. In class 11, in 12, you thought, just crack the board exam and crack the NEET, your life is set. And now you were thinking a couple of years back that once I get an MBBS degree, I will kill it, man. But now again, you have been astounded by the reality that this is a PG entrance, and this if you crack, your life is going to be set. But let me tell you, this also will not ease your life. It will just take you a step further towards another hurdle, because this is how life moves on. So, forget that concept that beyond this point, I will do this, and beyond this point, my life will be set. Is it clear? So, that is why I always say to my medico friends also that do not try to, segregate your life like other people and say that till 25 I will study this, then till 30 I will do my PG, then I will make a girlfriend, then I will make a boyfriend, then I will marry, at this age I will have kids, that I will have my first car. No, not at all. Our life cannot be segregated, because we are living the prime of our life and still we are studying only. And trust me, we have to do everything side by side also. So, whenever you get a chance, whenever you feel it is not distracting your goal, do enjoy also. Go for a trip after your exam. Do all the rest of the things that you always wanted to do. I hope you understood what I am trying to say. Do not think, because time is very, 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 very labile and it moves on. There's a very famous dialogue from a very famous Hindi movie. I love that dialogue that beetta waqt hai, kharch hum hote hain. So it is a time that passes by, but it is we who are being spent. It is not the time who is being spent. It is we who are being spent. So make your each second count. Do not let each second of your go in vain. So that's the way. And with this, let us move on to our today's agenda. And our today's agenda is a very, very important agenda. It's quite a conceptual agenda. And we shall be discussing electrolytes today. Yesterday I had discussed the cystic diseases also with you. I had discussed cryoglobulinemia also with you, which many guys had requested me personally. That, sir, it's a very important topic. Please discuss it with me. Yes, Akriti Agarwal has correctly caught the dialogue. She is correct. I took the dialogue from there only. Okay. So with this sip of tea, let me start today's class, and we shall begin today's class by discussing electrolytes. We shall start with electrolytes. And don't panic. I don't know why I'm sweating like this. Let me just switch on the fan. Yeah. So after some time I shall switch it off. Yeah. So let's start with the very important electrolyte in the very beginning, that is sodium. So let's start with sodium. And you know that the normal value of sodium is 135 to 145 milli equivalents per liter. Okay? Yes, AC का temperature कम है बेटा, but still I am sweating. Okay? So let's start with hyponatremia. And let me tell you, let's start with hyponatremia and let us start with the classification of hyponatremia. And hyponatremia is classified into, on the basis of volume status, it is classified into hypovolemic hyponatremia, euvolemic hyponatremia, and hypervolemic hyponatremia. Please write with me. I shall continue explaining it also. Okay, and we shall try to solve quite a few problems today, so that, because electrolyte, studying it isolatedly in theory does not help. You have to solve practical problems also, because that will how you will get practical clinical cases. Now, first of all, let me tell you one thing at the very beginning, that do not consider serum dysnatremias or sodium abnormalities to be isolated abnormalities of the sodium. Let me tell you, dysnatremias are more problems of the body water than of the sodium. So you will clearly see that whenever we are treating dysnatremias, that is hyper or hyponatremia, we are mainly targeting the body water, and the main task is to assess the volume status of the body. Is it clear? Because sodium and water are so inherently related to each other, so our only task and the first and foremost task is to delineate the volume status of the body. So we will classify it into hypovolemic, euvolemic and hypervolemic. Now, if it has the total body water and the serum sodium, in hypovolemic hyponatremia, the total body water is less, the serum sodium is further less. In euvolemic hyponatremia, the serum sodium is absolutely normal, the total body water is increased. And in hypervolemic hyponatremia, the sodium is actually increased, but the total body water is increased more, so you get a relative hyponatremic picture, which is basically a dilutional hyponatremia. Is it clear? So this is how things happen. Now, very importantly, let us first study hypovolemic hyponatremia. We classify hypovolemic hyponatremia into two types based on the urinary sodium. What, sir? Sir, it can be less than 20, or sir, it can be more than 20. Okay. Sir, if the urinary sodium is less than 20, it definitely means that the sodium which is less in the body is actually due to renal losses. So basically, I am losing the source of loss of sodium in my body is the kidney. Sir, why will I lose? I'm so sorry. I said just the opposite. This is extra renal. This is renal. So if I have less sodium in my urine, basically it means what? I am losing the sodium not from my urine but from somewhere else. So some extra renal loss, sir, where can I lose it from? Sir, where can I lose it from? I can lose it from my mouth, that is known as vomiting. I can lose it through my stools, that is known as diarrhea. I can lose it from everywhere, that is known as burns. Yes or no? Sir, I can lose it from my kidneys also, and that can be due to very commonly diuretics. So sir, if a patient is on diuretics due to any reason whatsoever, he will lose sodium from his urine because that is diuretic induced. What else, sir? If a person has aldosterone deficiency, the work of aldosterone is sodium and water retention. So aldosterone deficiency will cause hyponatremia, and the person will not reabsorb sodium through the cortical collecting duct, and the patient will lose sodium in the urine. Yes or no? And very importantly, there is a condition known as cerebral salt wasting. I don't know how many of you have heard about this, about cerebral salt wasting. It is basically you are losing salt through your kidneys but the cause lies in the brain, hence the name cerebral salt wasting. I hope I'm making sense to you. I hope I'm making sense to you. Very often a question is asked, say a person has a subarachnoid hemorrhage in the brain and 3 days later his serum sodium is found to be 118. He is excreting a lot of urine and there is volume depletion in his body. What is the cause? So you know it is due to cerebral salt wasting. And what is cerebral salt wasting due to? What is the reason for cerebral salt wasting? Please tell me. It is due to which hormone? It is due to brain natriuretic peptide. Because the brain secretes a hormone known as brain natriuretic peptide that causes natriuresis, causes loss of sodium in the urine, and you develop hyponatremia because you also lose water with it. So this is what happens. I hope I am clear. Now after hypovolemic hyponatremia, let's come to euvolemic hyponatremia. Now in euvolemic hyponatremia, the urinary sodium is more often than not more than 20. If the urinary sodium is more than 20, the euvolemic hyponatremia causes are number 1, very very important, hypothyroidism. Hypothyroidism, due to retention of some extra water in the body, the patient develops euvolemic hyponatremia. Number 2, the patient can have glucocorticoid deficiency. The patient can have glucocorticoid deficiency. Number 3, it can be due to a disorder known as syndrome of inappropriate antidiuretic hormone excess, YAD, that is SIADH, and I have taught you it is due to excess of ADH. It acts on the collecting duct and it causes all the water retention through aquaporin 2 on the luminal aspect, and water enters through aquaporin 3 and 4 on the basolateral aspect. So less of water in the urine, more of water in the body, urine is concentrated, blood is diluted, and you get hyponatremia. I hope you remember. I hope you remember. Next, drugs. Sir, which drugs cause euvolemic hyponatremia? Very very important, sir. It is drugs like tricyclic antidepressants and SSRI. Very notorious the drugs are tricyclic antidepressants and SSRI. Is it clear? Is it clear? Now, coming to hypervolemic hyponatremia. Now, hypervolemic hyponatremia, again, you will check for urinary sodium. It could be less than 20, it could be more than 20. Now, if it is less than 20, it means what? That the hypervolemia is not due to a renal cause. Because had it been a renal cause, my reabsorption would have been hampered and I would have lost sodium. So very easy, you know that there are 3 causes of hypervolemia. You read the edema. One is a renal cause, one is a liver cause, one is a heart cause. If it's a renal cause, your absorption will be defective and you will lose sodium. So it will be chronic kidney disease. While if it is an extra renal cause like chronic liver disease, chronic congestive failure or chronic heart failure, you will obviously not lose sodium and you will have this. So basically this is how you evaluate hyponatremia into hypovolemic, euvolemic, hypervolemic, where the causes are on the basis of urinary sodium. I hope I am clear to you. Now the beautiful thing, if you have seen, you will see that glucocorticoid deficiency causes euvolemic hyponatremia, whereas aldosterone deficiency causes hypovolemic hyponatremia. Now just see, both are adrenocortical hormones, but aldosterone deficiency causes water loss, so you have hypovolemic hyponatremia, whereas glucocorticoid deficiency causes euvolemic hyponatremia, and this is a very very important MCQ. This is a very very important MCQ. I hope I am absolutely clear to all of you. I hope I am absolutely clear to all of you. Clear? Now, SIAD is the most common cause of euvolemic hyponatremia. SIAD is the most common cause of euvolemic hyponatremia. This also is a question that has been asked previously. Is it clear? Absolutely clear? Now, very importantly, how do we divide hyponatremia into? Now, clinically, hyponatremia can be acute hyponatremia or chronic hyponatremia. Acute hyponatremia is hyponatremia that develops within 48 hours, whereas chronic hyponatremia develops beyond 48 hours. So basically, if you get a patient who has hyponatremia which has occurred in the last 2 days, that is known as acute hyponatremia, and if you get a patient whose hyponatremia has occurred beyond 2 days, 3 days, 4 days or 5 days, that is known as chronic hyponatremia. Is it clear? So you have understood a lot many things today, and just recalling the many chronics that we study in medicine. Let's just recall for me. What is chronic liver disease? Quickly answer for me. Chronic liver disease is a liver disease for more than equal to 6 months. Chronic kidney disease is a kidney disease for more than equal to not 6 months, 3 months. Chronic arthritis, you must have studied in rheumatology, is an arthritis that is present for more than equal to 6 months, weeks, days or minutes. It is present for more than 6 weeks. Chronic diarrhea is a diarrhea that is present for more than equal to 4 weeks. And chronic hyponatremia is a hyponatremia that is present for more than 2 days. So just see how you can revise all the chronic together, and just see how learning medicine becomes fun. So when you are studying rheumatology, you are studying chronic arthritis. You know that rheumatoid arthritis is the chronic arthritis, and you are studying chronic arthritis. Suddenly you are reminded, there's something known as chronic liver disease also. Chronic liver disease is 6 months, chronic kidney disease is 3 months, chronic arthritis is 6 weeks, chronic diarrhea is 4 weeks, chronic hyponatremia is 2 days. So just see the beauty of medicine. If you revise this way, if you correlate the entire medicine this way, learning will become so easy and you will never ever forget anything. I hope I am clear. Clear? Very good. Now, acute hyponatremia, how does this present? Acute hyponatremia, because it has occurred very rapidly. Usually acute hyponatremia has CNS features, and they can be, it is chronic arthritis more than 6 weeks, chronic diarrhea more than 4 weeks, chronic hyponatremia more than 2 days. Just a revision. You know everything, I know that. I'm just revising it with you because I just want to hammer it in your temporal lobe. Clear? Now, coming to acute hyponatremia can present with seizures, altered sensorium, chronic hyponatremia usually develops very, very slowly, sustainedly. The sodium gradually falls. So, you can't understand everything. So, basically, what does the patient present with? The patient has nausea. vomiting. The patient also has gait changes. Gait changes. You know what happened? A few months back, what happened was, my auntie, my cousin auntie, she called me and she told me that, you know, her mother, that was basically my cousin, grandmother, she was falling a lot these days. So, you know, she said, I took the history, she said that, Vivek, she was absolutely fine. And you know what happened? Ek to she's feeling a lot of, nausea these days. She doesn't feel like eating anything. And you know, in the last 2 days, she has tripped over 3 to 4 times. So, you know, when an elderly person falls, you think of many things. I could think of, I took the history, whether she has Parkinsonian features. I hope what I'm trying to say, a Parkinsonian feature with recurrent falls, what will you think of? That's an MCQ. Write down the answer. That's a separate story. So, you know, I took all the history. I tried to diagnose her, whatever, because I am living in Delhi. She stays in Calcutta. So, whatever I could do. But then I took the history. What are the comorbidities that she has? She said that she's a diabetic, she's a hypertensive. As soon as she said she's a hypertensive, I asked her that, auntie, please tell me what are the drugs she on. And you know, there was a big chart. She was having 15-16 medicines. And when I was waiting to hear one medicine, and then I heard a combination of medicine, and that she was taking a drug, a brand which had chlorthalidone and telmisartan. And can you tell me what class of drug is chlorthalidone? Chlorthalidone is a thiazide-like diuretic. Thiazide-like diuretic, which is very notorious to cause hyponatremia. I immediately told her, please stop this drug and get a serum sodium potassium checked the next day. And I knew what would come, and the serum sodium was 123 milliequivalents per liter. I then asked whether she has some, altered sensorium or any any seizing activity and stuff like that, but she refused. And then I gradually gave her salt supplementation and I gradually treated her. So, you know, that was a very, very subtle sign that I picked up, because gait changes are a very subtle sign of chronic hyponatremia. So if you take the history, yes, many of you are correct. What I was trying to ask you, many of you are absolutely correct. So, you know, if you take the history, you can understand that it was a thiazide-like diuretic induced hyponatremia, induced gait changes. Is it clear? Is it clear? Yes, Mr. Kashyap, it is progressive supranuclear palsy that I was trying to tell you. Okay? Though I've forgotten most of the neurology, but still, you know, whatever I remember. This is about the clinical features of hyponatremia. Now, come to the treatment part. Come to the treatment part. Now, if I ask you, what is the goal of treatment? The goal of treatment is, so basically what I'm trying to ask you is, if today you get a patient of a sodium 115, will today only you make it 135? No, sir. You know that how much you want to increase per day. You must know that. Yes or no? So what will you say, sir? What will you say, sir? You will say that, sir, in one day, the increase in sodium must be around 8 to 10 milliequivalents per liter. And in 2 days, it must be less than equal to 18 milliequivalents per liter. So, sir, if today the serum sodium is 120, at the maximum tomorrow you can make it 128. Please do not make it 138 in one single day. If you make that, you know what will happen? What will happen? Sir, havoc will happen. And you might as well be behind bars also. It is such a cruel entity. Behind bars is an exaggeration. I mean, you can be sued in a court of law for medical negligence, for professional medical negligence. I hope I am clear. Good. So this is the goal of treatment as to how you will treat the patient. Now, How you treat hyponatremia, again, basically depends on the classification as we had described. So the treatment of hyponatremia will again depend on whether the patient is hypovolemic, euvolemic, or hypervolemic. Sir, if the patient is having a hypovolemic hyponatremia, obviously sir, if I restore the volume of the patient, I have to not only give sodium but I have to give volume also. So basically the sodium will improve. So it is basically the treatment is hydration. So I will give the patient IV 0.9% normal saline. So you don't have to do anything big. You don't have to do anything fancy. Just give the patient normal saline and the patient will improve. If the patient is a patient of euvolemic hyponatremia, as I told you, because there is an excess of the total body water rather than the sodium being low, so do not give extra sodium. What you have to do is you have to restrict free water. So please do a free water restriction. Please do a free water restriction. Number 2. What else will you do, sir? Sir, apart from free water restriction, I can do something. I can give some extra salt also. Okay, I can give some extra salt also so that the sodium increases. But sir, you only told me that it was actually the water which was excess and not the salt which was deficient. So if you give extra salt, actually this is not the thing that you give. This is not the thing that you give primarily. Actually, you have to remove the extra water. So to remove the extra water, what will you give? You can give loop diuretics or you can give furosemide. So furosemide will inhibit the sodium potassium 2 chloride channel and will inhibit the water reabsorption. It is also a loop diuretic, so it will cause water loss and so you will have restoration. But sir, it will also cause loss of sodium. So I can have an aggravation of hyponatremia. Yes sir. So what I can do with furosemide, I can add oral salt. Very good. Next sir, what can I do? Sir, of course, I can give a drug which I have been taught in the first class of physiology of nephrology, that is V2 receptor antagonist. If you remember, on the basolateral aspect of the medullary collecting duct, and that drug was known as, you are correct, tolvaptan. Is it clear? But sir, will I give tolvaptan in any hyponatremia? No sir. There are some contraindications. I will never give tolvaptan in number 1, hypovolemic hyponatremia. Because in hypovolemic hyponatremia, the patient is requiring volume and not tolvaptan. Number 2, I will usually try to refrain from it in acute hyponatremia. Is it clear? Is it absolutely clear? And last but not the least, in severe liver disease. In severe liver disease also, tolvaptan is contraindicated. Is it clear? It is euvolemic, though the total body water is high, but it is euvolemic because there is no edema. Is it clear? Now, so these are the 3 contraindications where you will not give tolvaptan. Is it clear? Next is the hypervolemic hyponatremia. Mukesh Kumar is asking me, sir, how to check for 3 different conditions. That is your clinical skill, that you have to assess the volume status of the body. Sir, how do I do that? I can check from the tongue, I can check from pedal edema, from the JVP, from the crackles in the base of the lungs, from postural drop of BP, from postural tachycardia. All these will tell me whether the patient has an intravascular volume depletion, and if there is an edema, raised JVP, Krebs, I know this is a hypervolemic. If none are there, I know it's euvolemic. This is clinical skills. This is totally clinical medicine. That is why medicine cannot be learned at home. You have to go apply it at the patient and then learn it. Okay. Come to hypervolemic hyponatremia. Sir, how do you treat hypervolemic hyponatremia? Number one, of course, the treatment is primarily the same. You obviously do free water restriction. Here you give more of diuretics and you can give V2 receptor antagonist also. So basically the treatment of euvolemic hypervolemic is the same, but here the main treatment is diuretics. The main treatment in hypervolemic hyponatremia is diuretics, and the main treatment of euvolemic hyponatremia is free water restriction or tolvaptan. I hope you have absolutely clear. I hope this is absolutely clear to all of you. Is it clear? Very good. Sir, is this the only treatment option available? Obviously not. Obviously not. You have a lot more very important treatment available. That is hypertonic saline. So hypertonic saline, I call it the Ramband because it is the Brahmastra, or it is the last resort to treat hyponatremia in severe cases. Sir, when do you use hypertonic saline? Please understand the 3 indications of hypertonic saline. Number 1, acute hyponatremia. Number 2, severe symptomatic hyponatremia, that is less than 20. And last but not the least, if the patient has CNS clinical features. So you use hypertonic saline if it's an acute hyponatremia, that's a rapidly developing hyponatremia. Say for example, today a patient got prostate surgery, TURP. I know prostate surgery, post-prostate surgery, hyponatremia is very common. You can have a severe hyponatremia, sodium is 118, 117, 112. Then also you have to do. And last but not the least, if the patient has CNS features, some patients might even develop CNS features at sodium of 121, 122, 123. Still you will give hypertonic saline because that is your clinical judgment. I hope I am clear. Now, why will you not do rapid overcorrection of hyponatremia? Why will you not do rapid overcorrection of hyponatremia? If you do a rapid overcorrection of hyponatremia, what will happen is you can develop a condition, a very bad condition, which is known as central pontine myelinolysis. So it was earlier known as CPM, but as CPM has also vanished from our country, this CPM has also been vanished from medicine books, and it is now known as osmotic demyelination syndrome. It is known as osmotic demyelination syndrome. So now it is now known as ODS and not central pontine myelinolysis. Sir, why sir? Because sir, it was a misnomer. Neither was it purely pontine, nor was it purely central pontine, because it is actually the demyelination occurring in the brain. Though one of the most common site is the central pons, but it is not the monopoly of the central pons. Any part of the brainstem can get demyelinated from rapid correction of hyponatremia. And this is how you develop central pontine myelinolysis, which is now known as osmotic demyelination syndrome. I hope I am absolutely clear to all of you. I hope I am absolutely clear to all of you. Okay? Okay? Clear? Very good, very good. And CPM is now known as ODS. You know, I have seen a few patients of ODS also. When I was doing my MD residency, we had a patient, you know, he was basically a patient residing in the rural area, and he had a hyponatremia, and you know, he went to a very big doctor in his village, and this patient was given, of course, a very, very great drug by the great doctor that was 3% normal saline, and he was bombarded into his veins with 3% normal saline, and in one day only his sodium was raised from 108 to 128, and the patient was very happy. What a great doctor, sir! What a great doctor, sir! Just by the pulse diagnosing diseases, sir. So happy. And 7 days later he came to our hospital, and you know how did he present to us with? He presented to us with spastic quadriparesis. He basically was in a locked in state, so he was quadriparetic. Anything was not moving. He was in a locked in state, and the only thing was moving is he could only move his eyes. He had developed severe demyelination in brain stem. Is it clear? Is it clear? So the best thing is to give sodium very, very strategically and very, very calculatively. Now, what I have seen in 2 years back, a question had come to calculate the sodium deficit. So let me teach you how do we calculate sodium deficits. How do we calculate sodium deficit? Sodium deficit is equal to 0.6 it is total body water into body weight. So it is percentage body water into body weight into target minus serum sodium. So this is how you calculate the sodium deficit. So it is percentage body water into body weight into the target sodium that you want to achieve minus the present serum sodium. So let us take an example for all of you. Let us take an example. Let me give you a question. Say if a 60 kg male has come to you and he has presented to you with a sodium of 120. If the question is asked, in one day, say he has a sodium of 110. In one day, how much of 3% normal saline will you give? So how will you approach such questions? And let me tell you, such questions can definitely be asked in Central Institute exams. So you have to calculate the sodium deficit. Sodium deficit is percentage body water, and you know that males have a higher body percentage of water. So the percentage of body water in males is 60%. So it is 0.6 for males and Females have 50% body water, so it is 0.5 for females. Is it clear? This is the formula, or this is the thing that we will try to understand. Now, clearly see, sodium deficit is, because he is a male, it will be 0.6 into, how much does he weigh? He weighs 60 kg into, I told you that in one day you will maximally try to increase 8 milliequivalents. So your target in one day is 110 plus 8, 118 minus the present sodium, that is 110. So sodium deficit equals 0.6 into 60 into 8, which is equal to 36 into 8. I hope I am clear. Which is equal to 288 milliequivalents. So you have understood that by simple mathematics, the sodium deficit in your body is 288 milliequivalents of sodium, which is less in your body. Now, the question is, how much of 3% normal saline will you give the patient? Now, please see, you know by simple, you know from basics of fluids that 1 liter of 3% NS contains 513 milliequivalent. Is it clear? Is it absolutely clear? So 1 liter of 3% NS contains 513 milliequivalent. Now, so if I write it for the unitary method of mathematics, which I used to love, that if 513 milliequivalent are present in 1000 ml of 3% NS, 288 milliequivalent will be present in how much ml of NS? Very simple. You will do 1000 by 513 into 288 and by rough calculation what I can make out is it will somewhat come more than 500 and let me calculate it using a calculator. It is coming to around 561 ml. So you know, tough calculations will not be asked in the exams. The numbers will be such that it comes to a whole figure, so everything will, you know, get cancelled and the calculation will be very, very easy. So I hope you have understood this. Is it clear? I hope I am clear. I am again solving it for you. My problem was this is a very similar to an AIMS question that was asked 2 years back. Please see how the question is. The question is, a 60 kg male has come to you with a sodium of 110. How much of 3% NS will you give in one day? Now, the question can be simple. What is the sodium deficit? So, sodium deficit is male, so 0.6 into 60 into. This is the sodium deficit in one day, mind you. In one day. This is not the total sodium deficit. If the question was the total sodium deficit, then the calculation would have been 0.6 into 60 into the target sodium is 135, the sodium is 110, so it would be 36 into 25, which would be around 900 milliequivalents. Please understand the difference between the two. Please understand the difference between the two. Is it clear? Yes, it is 513. 513 is a fixed number. Clear? Is it clear? So, if you are asked a simple calculation, this is my body weight in a male, this is the sodium, what is the total sodium deficit? You will calculate it to be 0.6 into 60 into 135 is the normal serum sodium minus 110. So this is my serum, this is my sodium deficit, and If you are asked in one day how much sodium deficit is this? 288. So if 1 liter is 513 milliequivalent are present in 1000 ml. So 288 will be present in how many? Answer is 561 ml of 3% normal saline in one day, which is the maximum. Mind you. I hope I am absolutely clear. Why 118? Because 118 is 110 is the serum sodium right now, and the maximum correction I want to do is 8 milliequivalents per liter in a day. So 110 plus 8 is 18. I hope I am clear. 110 is the present serum sodium, 118 is the target serum sodium. That is why it is 118. Okay? I have made it absolutely clear. I have gone very slow in this topic because I know it is difficult. It is not given in Harrison properly. That is why I have made 118. So if you are asked in one day, my target sodium will be 118. If you are asked no days given, total sodium deficit, then you will write it 135. Clear? Absolutely clear? Very good. You will not be asked very tough calculations, and I have given you a tougher so that you can now do anything now. You can do anything. There is nothing known as 2% NS. There is nothing known as 2% NS. Either you have a normal saline, or you have a half normal saline 0.45%, or you have a 3%. Okay, so we have completed hyponatremia. You have completed hyponatremia. So hyponatremia is completed. Hypernatremia is not required. Whatever is required, which will be discussed in your endocrinology classes. So let me straight away jump to a very important ion. That is potassium. And you know that the normal level of serum potassium is 3.5 to 5.5 milliequivalent per liter. Clear? This is about serum potassium. Now, in serum potassium, what is important, I will teach you only that. You have already been taught in your ECG, I think the changes of serum potassium, the ECG correlation of serum potassium. And just to revise a few MCQs, if I ask you, the first change in ECG is tall peaked T wave. So you get a tall peaked T wave, which is the first change or the earliest change. Okay, then you get, after tall peak T wave, you get loss of T wave. Then you get widened QRS. And then you get what is known as a sine wave pattern. What you get is known as a sine wave pattern, which is a very important MCQ. So basically, in sine wave pattern, there is no P, there is no QRS, there is no T. You straight away get a sine wave pattern. Is it clear? So this is the last change in ECG. Sir, a girl asked me, why sir, this is the last change in ECG. I said, because beyond this change, the person does not survive on planet Earth to show you more changes. So the person said, enough, I cannot teach you any more medicine and no more electrocardiogram. This is the last I can serve you. Okay. So, always be thankful to patients. So, sometimes it so happens that, we are very busy in our OPDs and in our wards, especially in the medical colleges. And, we tend to, sometimes, I would not say be rude or misbehave, but, we tend to, ignore the agony of those patients. But we forget that those are the patients who actually are teaching us medicine, surgery, gynae, pediatrics, and all the other subjects also. So, just take a second out for them and respect them and thank them that that sir, you are there, ma'am, you are there, so I am being able to auscultate S1, S2, S3 and S4. So am I able to appreciate the loss of QRS in an ECG. Clear? Is it clear? So this is the sine wave pattern. So two MCQs are asked here. One is the earliest change and one is the last change. Very commonly you get these ECG changes. Is it clear? In hyperkalemia. Now, in hyperkalemia investigation, that approach you will never be asked. You can only be asked one thing, which I will teach you. There is something known as transtubular potassium gradient. There is something known as transtubular potassium gradient, and actually, practically speaking, this concept is getting obsolete day by day. Okay, so transtubular potassium gradient, you can be asked, sir, what is this? Normal TTKG is between 8 to 9. If you get normally in 8 to 9, if the patient has hyperkalemia, first let me tell you what is TTKG. Because if I don't tell you that, it will not be enough. So TTKG is equal to urinary sodium by serum sodium divided by urinary osmolality. I'm so sorry. How can it be sodium? It is urinary potassium by serum potassium by urinary osmolality divided by serum osmolality. By serum osmolality. Is it clear? So this is TTKG. Just try to understand the formula, and I will only explain you in a nutshell. Do not try to go into too much of depth because it is not required. Okay, I have somewhat drawn the shape of the pancreas. I don't know. So just try to understand what I'm trying to tell you. So TTKG, the normal value of TTKG is 8 to 9. If there is hyperkalemia, you would want to secrete more of potassium in the urine, yes or no? If yes, you would want to have a higher TTKG. You would want to have a higher TTKG in hyperkalemia. So normally in hyperkalemia, the TTKG is more than 10. And in hypokalemia, the TTKG decreases to less than 3. To less than 3. I hope I am clear to all of you. I hope I am absolutely clear to all of you. Okay? Is it clear? Is it absolutely clear? Yeah. I would just request you to excuse me for a second. At least somebody is there at the door and there's nobody. Just excuse me for a second. Yeah, I'm so sorry. So basically what I was telling you was TTKG is urinary potassium by serum potassium by urinary osmolarity by serum osmolarity. Normally it is 8 to 9. It is in hyperkalemia it increases and in hypokalemia it decreases. So basically what is TTKG? TTKG is a measure of distal tubular potassium secretion. So basically it measures in the form by this formula we can understand whether my distal tubular potassium secretion is intact, yes or no, is intact or no. And you know that the distal tubular potassium secretion is mediated by aldosterone action. Is it clear? So if a normal person has hyperkalemia, his potassium secretion will increase in the distal tubule and try to increase the urinary potassium in the urine. This is the normal phenomena of TTKG. In hyperkalemia, you expect a higher TTKG, but if in hyperkalemia you get a TTKG of less than 5, you get a TTKG of less than 5, then you know that it is due to, or better, let me write down in this format. Wait, let me write down in this format. TTKG. Normally, the normal TTKG value in hypokalemia, in hyperkalemia, the normal TTKG value is 8 to 9. In hypokalemia, it is less than 3 because you will not, in hypokalemia your blood has less potassium, so you will not secrete more potassium in the distal tubular fluid. In hyperkalemia, it should be more than 10. In hypokalemia, if you get less than 5, it means there is aldosterone deficiency. It is either aldosterone deficiency or it is aldosterone resistance. I hope I am clear to all of you. So basically, if you get an MCQ that a patient has come to you with a hyperkalemia potassium of 7 or 8 and his TTKG is 4, his TTKG is 3, so you know in a hyperkalemic patient his transtubular potassium gradient, which is a measure of the distal tubular potassium, which is a measure of aldosterone induced distal tubular potassium secretion, should be high, but it is low. It means there is aldosterone deficiency or there is aldosterone resistance. This is the only MCQ that you can be asked from this topic. I hope I am clear. I hope I am absolutely clear. Is it okay? Is it absolutely okay? Very good. So we have completed hyperkalemia ka evaluation and ECG changes, and without any delay, let us start the management of hyperkalemia. The management of hyperkalemia begins by measuring the serum potassium. So you will see how much is the serum potassium. Sir, if the serum potassium is more than 6.5, you put him under one bracket. Or sir, the serum potassium is between 5.5 to 6.5, you put him under this bracket. If it is between 5.5 to 6.5, you see whether the patient has ECG changes. Whether the patient has ECG changes or not. If the patient has ECG changes, or heart rate changes, you have to put him again under this bracket. If not, under here. I hope I am clear to all of you. So basically, you treat hyperkalemia on the basis of serum potassium levels and heart rate and ECG changes. Okay? Okay? So if your potassium is more than 6.5, you straight away put him under this bracket. If your potassium is less than 6.5, then you will see whether the patient has ECG changes or not. If the patient has ECG changes, you will put him here. If the patient does not have ECG changes, you will put him here. Let me just switch on my phone, which is getting off recurrently. So why, sir, have I segregated myself into these two branches? Because, sir, if your potassium is more than 6.5 or if the patient has ECG changes, it is a medical emergency. You cannot fool around here. Sir, it is a medical emergency. You have to be high on your adrenaline. You have to be on your toes to manage this situation. It is a medical emergency. Sir, how will I manage this situation? I will manage it by number 1, injection calcium gluconate. I will give the patient, number 2, please leave some space in between. Please leave some space in between. I will give the patient, number 2, insulin dextrose infusion. I will give the patient insulin dextrose infusion. Clear? Clear? Yeah. So my app had suddenly shut down. So I will give the patient insulin dextrose infusion. Sir, what else do I have? What else do I have, sir? I also have a drug which is known as salbutamol nebulization. I will give the patient salbutamol nebulization. I can give the patient injection sodium bicarbonate. And last but not the least, sir, the ultimate resolution, the ultimate step in the hands of a nephrologist, that is dialysis. I told you that the treatment of refractory hyperkalemia, sir, agar koi bhi cheez se I cannot control potassium, the last resort in my hands is of course the Brahmastra, which is dialysis. Sir, if the potassium is lesser, it is mildly high and the patient does not have any ECG changes, sir, what is to be done? Then, sir, you can be relaxed, you can be calm, you can easily give the patient, number 1, potassium restricted diet. I think I told you the story of my patient yesterday who was consuming a lot of nariyal pani despite having explained a lot of things to him. Number 2, I can give the patient potassium binding resins, which contains calcium polystyrene sulfonate, so we give the patient potassium binding resins which contain calcium polystyrene sulfonate, of course. So this is how you will treat the patient, and of course what you can do is you can stop drugs that cause hyperkalemia. And of course, when you are a nephrologist and you were talking about hyperkalemic drugs, you cannot miss this drug. So whenever I am given a call from other departments, especially surgical department, for hyperkalemia. Surgeons get baffled by these electrolytemias. They have no clue whatsoever to understand that what is what. Okay, so to how to manage hyperkalemia, and they very often will give you calls and they will tell you that the potassium is very high. Over the call, they will tell you that potassium is very, very high. Please come and see the patient fast. And when I go and see the patient, the potassium is 5.7, 5.8. I go there and laugh at myself. I say, if this is, high for you, I really don't know what to say, because this is, bread and butter for us. So, it's good that, they give reference to us because for such things, because if they would not call us, how would the cycle run? So thankfully, they give us calls for such things. Is it clear? Is it clear? Very good. Now, just a second, I'm getting recurrent calls from a number. I'm just trying to figure out who is this. Who is this? It's an unknown number. Just hope it's not a very, very, yeah. So leave that. So this is how you treat hyperkalemia. Now coming back to very important MCQs. Coming to injection calcium gluconate. Sir, injection calcium gluconate is the first drug to be given in severe hyperkalemia. This was a very, very important question. Very, very important question. It is the first drug to be given in severe hyperkalemia, or if the patient has ECG changes. Is it clear to all of you? Insulin dextrose is the drug which is the fastest drug to reduce potassium. So fastest drug, no, it was not a nagging neighbor auntie. Okay. So Mamta Hunur says, tell me the number, kaat ke rakh denge. Do not worry, no need to cartofy. I am strictly a non-violent person. Okay. So first drug to be given in severe hyperkalemia is calcium gluconate, and the fastest drug to reduce serum potassium is insulin dextrose infusion. Clear? So just tell me one thing, will calcium gluconate reduce potassium? Does calcium gluconate reduce potassium? Yes or no? The answer is obviously no. Sir, then why are you giving calcium gluconate, sir? Why the hell are you giving calcium gluconate? I am giving calcium gluconate because it is used to stabilize the myocardium. Because, sir, hyperkalemia can immediately cause cardiac arrest. It can cause ventricular arrhythmias very quickly. It is very, very notorious to cause ventricular arrhythmias, and the patient can be immediately transmitted vertically to heaven. So, calcium gluconate is the first drug, but it does not reduce serum potassium. So, if you are asked which is the drug which fastest reduces potassium, answer is insulin dextrose infusion. I hope I am absolutely clear. So, this is how you manage hyperkalemia. So if I give you a clinical scenario that a patient of CKD with a creatinine of 5 who was on ACE inhibitors to manage his blood pressure has come to the casualty, you go and examine the patient's pulse is 34 per minute. His serum potassium is 7.8 milliequivalents per liter. Which drug will you give him? The first. Answer is injection calcium gluconate. Why, sir? Sir, to buy some more time, so that I have some more time, because till the time I don't, do something, the patient does not travel to heavens. If the same question, a CKD patient, creatinine of 5, potassium of 7.8, which drug will reduce his potassium fastest? Answer, insulin dextrose infusion. It is actually insulin that will cause rapid shiftward of the potassium ions from the blood to the intracellular compartment. But insulin can cause hypoglycemia. To prevent that, you give dextrose. Is it clear? Is it clear? Absolutely clear? Very good. So, this is on the left hand, which I'm saying is a medical emergency. You need to be on your toes. And the worst thing that you can have is, have a junior who is absolutely lazy and lethargy. So, I was in my first year of medicine residency and there was an intern. She was a girl, very sweet girl, a pretty girl also. Let me tell you, do not take me otherwise. So that girl, I was taking my rounds and the patient, I was seeing that the patient is getting slightly drowsy. I checked for his pulse. He's CKD patient, dialyzed 3 days back. He was bradycardiac. I immediately took an ECG, and ECG I saw the sine wave pattern. So I was so excited to see the sine wave pattern. I immediately knew that it was hyperkalemia. I told that girl, "Beta jao, dood ke calcium gluconate lekar aao." And the girl, she was walking in slow motion. She went up to the sister table and she told her, "Sister, please give me injection calcium gluconate." And she took the injection calcium gluconate, she tore the wrapper of the syringe and she was slowly, loading the syringe with calcium gluconate. And I was looking at her that how, please tell her that this life is at stake. And I really wished that her parents had checked her thyroid profile. I really wished that, her parents had, uske parents ne kuch, had given her some thyroxine tablets in water. I told her later on to check her thyroid status. Trust me, she was hypothyroid. Trust me, she was hypothyroid. Okay. So, that's a separate story. That's a separate story. So, this is how you treat hyperkalemia. Now, the latest thing that you need to learn in this portion is, which is very, very important thing, that potassium, what is new in this topic? There are two new potassium binding agents. There are two new potassium binding agents that have come into the market. Number one is patiromer. And number two is zirconium cyclosilicate. So the two newer potassium binding agents are patiromer and zirconium cyclosilicate. Is it clear? Is it clear? Why salbutamol, beta? Again, you are forgetting your pharmacology. Read in second year, KD Tripathi. Salbutamol also acts on the beta 2 receptors of the lungs and of the rest of the body, causes shiftward of the potassium inside the cells. So, if you remember the side effects of salbutamol, I used to remember it causes hypokalemia, it causes tremor, it causes tolerance. I think I am correct. I don't remember exactly, but these were it. It causes hypokalemia, it causes tachycardia, it causes tolerance. And it causes 3T and hypokalemia. Tremor, tachycardia, tolerance and hypokalemia. Please don't quote me. I may be wrong, but this is how I remember. Okay, so these two are very, very important new potassium binding agents which are of very importance in the exams to come. Clear? Clear? Some people have been requesting me to repeat TTKG. Let me listen to you and let me do it once. Let me do it once. TTKG is a transtubular potassium gradient. So basically it denotes how much the distal tubule of the nephron is secreting potassium. It is a measure of the integrity of the distal tubular potassium secretion. Now, it is calculated by this formula: urinary potassium by serum potassium to urinary osmolality to serum osmolality. Clear? So, basically, TTKG high means that the urinary potassium secretion is on the higher side. Normal TTKG in normal circumstances, the numerical value is 8 to 9. When you have a hypokalemia in the blood, obviously you would not like to lose potassium in the urine because you have less of potassium in the blood. So your TTKG will be low, so your potassium secretion in the urine will be low. Yes or no? That is why it will be less than 3. if you have a hyperkalemia in the blood, your TTKG ought to be more than 10. Yes or no? Because you will lose more potassium in the urine. Very good. But if your TTKG is less than 5 in hyperkalemia, it denotes that the distal potassium secretion in the tubule is less, which is an indication of aldosterone functional defect. I hope I'm absolutely clear to you now. And the management also. Clear? Now, after hyperkalemia, we shall now discuss hypokalemia, which is not, please, if you want to write the name of the agents, I am just showing it to you once more. One is patiromer, and one is zirconium cyclosilicate. Clear? It is a new potassium binding agent. It is zirconium cyclosilicate. Clear? Good. Now, come to hypokalemia. In hypokalemia means that the potassium is less than 3.5 milliequivalents per liter. This is the definition of hypokalemia. Please stop your side talks. Advise sodium bicarbonate, good question. Usually hyperkalemia, as I told you earlier, also associated with acidosis. So that corrects the acidosis also. And when the acidosis is corrected, automatically the potassium correction is also there because of the H plus K plus antiport in the cortical collecting duct. It functions as to preserve potassium, and the potassium secretion is less. I hope I am clear to all of you. Clear? Now Debashish Nanda, please understand whatever I am trying to say. Do not try to study more. Okay? मेरी बात मानो. Whatever I am telling you, these are very complicated topics. You know, each electrolyte disorder can be taught for one whole class, which could be of 4 to 5 hours. Okay? I have only made the NEET super specialty curriculum, which is for the DM entrance examination of nephrology, and there electrolyte disorders are very vast. But I know how much to give whom. So I have had the pleasure, let me tell you this, that's a side thing. I have had the pleasure to teach nephrology to a very wide array of students. I have taught nephrology in China, that is to the people who are studying from China and who are planning to appear for the MCI clearance exam. I teach nephrology very regularly to MD entrance students. I teach nephrology for the DM entrance exam also, and I have also taught nephrology to my nephew who is in class 8 with the kidney diagram and the ureter and the IVC and the aorta, that old diagram that we used to study. But I do not teach him about patiromer and zirconium cyclosilicate, and I do not teach you about the trials of IgA nephropathy and the trials of ANCA vasculitis. So this is how I know where to draw the line, because if I mix up things, because teaching is not about what I know, teaching is about what you need to know. Is it clear? Is it clear? Is it clear? Yeah, some people are talking. Yes, I didn't go to Wuhan. I had gone to I remember that dialogue. I don't know from which movie, from Lagan. He says that pronouncing Sasuri jeep fisal jati hai, and that the name of the city was Chengzhou. I had gone to Chengzhou. I stayed there for 8 days. And I had gone to Chengzhou. So very, very that, and the person who was behind sending me and all that was definitely your Dr. Siddharth Mishra. So I don't know now when will I get the opportunity to go there. Okay. So there I had the opportunity to teach the entire medicine, and I discussed the entire medicine in 8 days. So, talking about hypokalemia, what are the ECG changes of hypokalemia? What are the ECG changes of hypokalemia, you know that you get ST depression. Please do not have side talks. You get decreased amplitude of T wave. You get a U wave. You get QT prolongation, increase QT interval, and of course you get U waves in ECG. Okay. So this is the MCQ which is often asked, that what are the ECG changes of hypokalemia? What is more often asked? It is prolongation of QT interval, and you get U waves in ECG, which is very, very common question, and that is what you get in the ECG also. Clear? Clear? Now, come to the management of hypokalemia. In the management of hypokalemia, how do you manage hypokalemia? You check for the serum potassium, and if the serum potassium is less than 2.5 milliequivalents, you put the patient under this category. If the potassium is between 2.5 to 3.5 milliequivalents per liter, you put him here. If the potassium is between 2.5 to 3.5, as with hyperkalemia, check for ECG or heart rate changes. Check for ECG or heart rate changes. If the answer is yes, put him back here. If the answer is no, let him be here. So, what I am trying to say is, if the potassium is less than 2.5, or if the patient has ECG or heart rate changes, you have put him here again, because this is a medical emergency. Whereas this you can treat aram se. You can treat easily. And how do you treat severe hypokalemia or hypokalemia with ECG changes? You have to give the patient IV potassium chloride. You have to give the patient IV potassium chloride. Whereas in mild hypokalemia without ECG changes, you give the patient oral potassium chloride. The dosage is not required. The rate of infusion is never asked. So I will not bombard you with that. Clear? Is it clear? I will not bombard you with that. Just remember, all hypos prolong QT. If you are ever asked what is the causes of QT prolongation, all hypos. Hypokalemia, hypocalcemia, hypomagnesemia. Okay? Oral potassium chloride. And yes, you can have a potassium rich diet. अब पेशेंट को बोलो कि go to Kerala and have as much coconut water as you want. Have coconut water, have bananas, have fruits, have citrus fruits, anything that you want. Clear? Anything that you want. Because you know, coconut water is the richest naturally occurring source of potassium. Coconut water has this beauty. But many people think it has a lot of medicinal importance, and people think, you know, if you fall sick, leave amphotericin B, leave, you know, piperacillin, tazobactam, leave meropenem, they will not save you. Only coconut water can save a person if he is critically ill and is in ICU. This is the thing that people think. So this is the management of hypokalemia. Is it clear? A very important thing is, if you get a patient of refractory hypokalemia, sir, what do you mean by that? Sir, sometime it happens that, sir, I had a patient whose potassium was 2.7, I was given the call. So I saw the potassium is 2.7, and you know, ideally I should have given oral potassium only, but I saw that the patient had been posted for a surgery the next day. So I was called to correct the potassium immediately. So I gave the potassium a potassium chloride drip, and I wanted the patient to be corrected. Next day the surgeon gave me a call. He said, Vivek, what are you doing? He was a friend of mine. Vivek, are you not being able to correct potassium in one day also? It hurt my ego. I went and saw the potassium was still 2.9. I had given him around 120 milliequivalents of potassium IV. Still the potassium had not increased, only by this small bit. That very second I understood that what is the reason of potassium not being increased properly. And immediately I checked for another thing, that was serum magnesium. Why, sir? Whenever you get refractory hypokalemia, always check serum magnesium, because hypomagnesemia causes hypokalemia. So it is a very, very common cause to get hypomagnesemia, which is not letting you correct hypokalemia. So a very important cause of refractory hypokalemia is hypomagnesemia. And let me give you, this is a question, and one girl has already, Shweta Singh, and I would like to give a round of applause to Shweta Singh. Kudos to you for beautifully answering this. She has correctly told me that why hypomagnesemia causes hypokalemia. Okay, and if I have to explain it to you, if you remember my thick ascending loop of Henle or my distal collecting duct, you remember here was a channel which had sodium, potassium 2 chloride, and here you had a potassium channel that was sending potassium outside, and the name of this channel was ROM-K. The name of this channel was ROM-K, and let me tell you, an inhibitor of ROM-K is magnesium. Sir, what do you mean by this, sir? Sir, magnesium is that Darwan, is that gatekeeper which is standing at the gate of ROM-K, and it will say that pran jaye but potassium na jaye. He says, I will not let potassium go out, I will block the door. He says to the villain in Bollywood style that if you have to go there, you have to go upon my lash. So potassium is not being able to go out in the presence of magnesium. Only when there is hypomagnesemia, there will no be Darwan, there will not be a guard, and what will happen is all the potassium will come out into the urine, and from the urine it will go out into your pots, and you will not have this. Clear? So you will have hypokalemia. That is why I say that hypomagnesemia is a cause of hypokalemia. Clear? With this we have completed hypokalemia also. So we have completed sodium disorder, we have completed potassium disorders, and now we shall go on to calcium disorders. I think you have been taught calcium in endocrinology. So should I not teach you? I think you have been taught this, right? I think my work has become easy because calcium has already been taught to you in your endocrine class. Yes? Yes or no? Quickly tell me. No, I'm not asking anyone to learn Hindi. Please do not have side talks. It is absolutely okay. I am absolutely okay with English, though I'm still learning English, but I will try to be as much fluent as possible. Clear? So endocrinology, you have been taught for calcium. So is my work easy now? So, okay, I understood your feelings. The normal calcium levels, as I have told you in the very first class, is 8.4 to 10.3 milliequivalents per liter. This is the normal calcium. Roughly we say it is 8 to 10. Clear? So in any calcium disorder, the very first task is to confirm corrected calcium. So in any disorder, if you are asked that please correct it or calculate it, first you will tell me that, sir, first let me take out the corrected calcium. This is very analogous to, in my medicine clinics class, I was always taught that, in your medicine Viva exam, in your medicine practical exam, teacher lays a trap for you. Teacher lays a honey trap for you, and he tells you, beta, please show me icterus, and you have mugged up. You have mugged up Dr. Kundu's book, you have mugged up Hutchinson's and McLeod's, and you remember icterus is seen in the upper bulbar sclera, it is seen on the nail bed, it is seen on the heart palate, it is seen on the skin, body, nails and all that, and you immediately go and see the patient. But the crux of the matter is, you have to tell the patient, you have to tell your teacher, sir, I would first like to go in sunlight and examine the patient. The moment you say that, sir, I would like to go to sunlight to examine the patient, sir, get some orgasmic pleasure, and he tells you, very good, no need to show me the sites of angina icterus, I only wanted to hear this. So these are some tricks. Similarly, if I ask you about calcium disorders, first ask me, sir, please tell me corrected calcium, okay? Because calcium is 40 to 45% protein bound. Calcium is approximately 50 to 55% free, and it is in 40 to 45% protein bound. Clear? So you have to know that calcium values will be spuriously high or low in protein disorders. So if a protein is low, say in a chronic liver disease or in a malnutrition, in hypoalbuminemia, nephrotic syndrome, or the calcium will be spuriously low. So you have to first calculate the corrected calcium, and the corrected calcium is zero. Corrected calcium is whatever the calcium is plus 0.8 into 4 minus serum albumin. So the corrected calcium is calcium plus 0.8 into 4 minus serum albumin. Let me give you an example. There is a patient whose calcium is 6.4. His serum albumin is 2 grams per dl. The option is, how will you correct the serum calcium? Option A, give IV calcium. Option B, give calcium tablets. C, give both. D, don't treat it, or whatever. So how will you approach this question? Sir, first I will calculate the corrected calcium, which will be 6.4 into 6.4 plus 0.8 into 4 minus 2, because albumin is 2. It is equal to 6.4 plus 0.8 into 2, which is 1.6. So it will be 8 milliequivalents per liter. So apparently the calcium was appearing to be low, 6.4, but now the calcium is almost normal or slightly low, and this calcium will not be requiring a lot of treatment. I hope I am making sense to you. I hope I am absolutely clear to all of you. This is how you calculate the corrected calcium. Now, coming to hypo and hypercalcemia. Sir, coming to hypo and hypercalcemia. Sir, hypocalcemia is defined as calcium of less than 8.4, and hypercalcemia is a calcium of more than 10.3 milliequivalents per liter. Clear? Is it clear? Good. Now if I ask you the clinical features, I will just say in short, whatever is relevant to me right now. If I ask you the cardiovascular features of hypocalcemia, I told you all hypos prolong QT. They will cause prolongation of QT interval. They can cause tachyarrhythmias. They can even cause ventricular tachycardia, which is of course a tachyarrhythmia. Coming to hypercalcemia, they shorten the QT interval. They cause conduction blocks. So hypercalcemia can cause conduction blocks and they can cause bradyarrhythmias. So this is the paradox, that hyper will cause slow the heart and hypo will fasten the heart. Clear? The concept lies in the action potential diagram and the curve and the phases of action potential, which I do not have the time and patience to explain it to you right now. I know all of you know it, all of you are masters. Very good. Next, after CVS, come to nervous system, neurological. Sir, in neurological also, it is the same thing. Hypocalcemia will cause irritation of the nervous system and that can lead to seizures. That can lead to seizures. Hypocalcemia can cause seizures. The patient will be irritable. The patient can have a Vostek sign. The patient can have Trocheau sign. The patient can have Trocheau sign also. Coming to neurological features of hypercalcemia. Now sir, hypercalcemia will depress the neurological system. Hypo excited the neurological system, whereas hypercalcemia will depress it. Sir, what will it cause? Sir, it will cause lethargy. It will cause depression. यहाँ पे there was excitable, there was Vostek sign. यहाँ पे there will be hyporeflexia. So this is how hyper and hypocalcemia manifestations differ. Clear? Clear? Vostek sign and Trocheau sign you have been studying from time immemorial, right from your physiology lectures, and I hope you know. Okay? I hope you know. If you not, a few days back I had shared a photograph of Vostek sign, a beautiful diagrammatic representation of Vostek sign. You can check it on the club. Clear? This is how they present. After neurological features, come to renal. Now hypercalcemia is on the right. Okay. So hypocalcemia does not have much of a hyporeflexia. Hyporeflexia. Yeah. So renal features of hypocalcemia is not that prominent. Leave this. Talking about hypercalcemia renal feature, of course, you have nephrocalcinosis. So hypercalcemia which cause hypercalciuria, more of calcium will come out in the urine and that will get deposited in the kidneys also. That can cause renal stones, that can cause nephrocalcinosis, and it causes nephrogenic diabetes insipidus, because you must know that hypercalcemia inhibits water reabsorption in the kidney. Hypercalcemia inhibits water reabsorption in the kidney and it causes water loss. Because it causes water loss, despite the presence of ADH, that is known as nephrogenic diabetes insipidus. Clear? Is it clear? When I think of diabetes insipidus, I am reminded of an intern that I had. So I was taking my rounds and I usually, while on my rounds, I usually keep asking questions to my interns and my juniors. Just revising, it interests me. So I just asked my intern that, how many types of diabetes are there? And I actually meant to ask how many types of diabetes mellitus are there. And the intern he basically outdid me and he answered, sir, there are two types of diabetes. One is diabetes insipidus and one is diabetes mellitus. So I was absolutely clean bowled because I was expecting him to answer type 1 and type 2 and then I would ask him some more questions, but he actually outsmarted me and he was absolutely right that, sir, there are two types of diabetes, insipidus and mellitus. And after diabetes mellitus, there are many types of diabetes mellitus, whatever. That would have been a separate question. Clear? So this is how hypercalcemia presents to you with. So you have to understand, hypocalcemia excites the heart, excites the brain. Hypercalcemia depresses the heart, depresses the brain. Is it okay? Is it absolutely okay? Good. Now, how will you approach? How will you approach to hypocalcemia? Calcium has been a very, very favorite topic of all the exams, especially of the central institutes, and that is why I want to cover calcium in details. When you get hypocalcemia, how will you approach? Let me teach you, and I will teach you a very good working algorithm. And this is how I also see my patients daily. So not only will it help you to examine, to solve MCQs, but it will help you to approach patients in real life also. So if you get low calcium, the next task the next task that you have at hand is to check for serum parathormone. If you get sir, if I get the serum parathormone to be high, I know the calcium is low. Probably the calcium is low. I'm so sorry, I'm not talking about parathormone. I will check serum creatinine. If I in hypocalcemia, if I get a high creatinine, I know why do I have hypocalcemia, and the reason is the patient has CKD. It is due to CKD that the patient has hypocalcemia, and the patient will have hyperparathyroidism, which is basically secondary hyperparathyroidism to compensate. And I hope you remember my flowchart that I taught you yesterday about high bone turnover disease. That was a beautiful flowchart, and I hope you remember. If the serum creatinine is normal, so you have excluded CKD, so the hypocalcemia is not due to CKD, the next thing that you will do is you will check for serum parathormone. You will check for serum parathormone, and if the parathormone is low, you know that you have hypocalcemia due to hypoparathyroidism. It is due to hypoparathyroidism that could be congenital, that could be acquired, could be due to surgery, could be due to radiation or whatsoever, any acquired cause of hypoparathyroidism. Now, if the serum PTH is not low, it is high, it means that the serum PTH is trying to compensate for your low calcium, and then the PTH is not at fault. So what do you have to see? You have to check for vitamin D, because if the vitamin D can be two things, sir, if the vitamin D is low or it is normal. Sir, if the vitamin D is low, you know it is vitamin D deficiency, which is a very common cause of hypocalcemia in Indians especially, and if the vitamin D is normal, you know it is vitamin D resistance or it is basically vitamin D resistance. Clear? So this is how you evaluate hypocalcemia. Can you please understand the flowchart? I am repeating once more. So there are 3 steps to evaluate hypocalcemia. Step number 1 is check for serum creatinine. Step number 2, check serum parathormone. Step number 3, check serum vitamin D. There are 3 steps to check for. One is serum creatinine, one is serum parathormone, and one is vitamin D. If you check through these 3 steps, you will never ever miss a cause of hypocalcemia. Please understand, once again, I am repeating it. If you get hypocalcemia, very common cause of hypocalcemia is CKD. So check for serum creatinine. If it is high, you know it is CKD induced hypocalcemia. You know it is in the high bone turnover disease, you know that. Now, if the serum creatinine is normal, so you've excluded CKD, check for PTH. If the PTH is low, so it was a parathyroid gland which was secreting less parathyroid hormone, and that was causing less of calcium. That leads to hypoparathyroidism. If the PTH is also normal, now the culprit could be vitamin D. So if vitamin D is low, it is due to vitamin D deficiency. If vitamin D is normal, then you know that is a vitamin D resistance. So it is probably the defect of the vitamin D receptor. It is the end organ defect. Is it clear? Clear? Absolutely clear? Why hypocalcemia and CKD? After the entire Ramayana, you're telling me why hypocalcemia and CKD? I taught you yesterday in so much of details. Please go back to yesterday's class and try to recall. So, whenever you evaluate hypocalcemia, in one breath you can write blood for serum creatinine, vitamin D and IPTH. And whenever you do this, you can immediately run the flowchart in your brain and you can understand what is the cause of what. Clear? After hypocalcemia, come to hypercalcemia. This is slightly complicated. In hypercalcemia, you will check for, first of all, you will check for serum PTH levels. If the serum PTH level is low, or it could be normal or high. Sir, if the serum PTH level is low, then I mean that parathormone is not the culprit behind hypercalcemia. I know there could be something else, and there is another notorious hormone which is parathormone related peptide. I will check for parathormone related peptide. If PTH-RP is high or if PTH-RP is low. If PTH-RP is high, I know PTH-RP is a marker of hypercalcemia of malignancy. Hypercalcemia of malignancy. If PTH-RP is low, then I know there could be some other cause also. So I will not stop evaluating. I will check for 25 hydroxy vitamin D and 125 hydroxy vitamin D. That is calcidiol and calcitriol levels. So basically I will check for calcidiol and calcitriol levels. Sir, if both are high, I know that it is my same patient, that same Dadaji who had come to my clinic complaining, sir, why did I get a bone fracture, sir? I was taking this vitamin D capsule daily for the last 3 years, sir. So the patient has developed vitamin D toxicity. if the patient has both, if the both are low, so you know that vitamin D has nothing to do with hypercalcemia. In fact, you have low vitamin D. So that cannot be due to vitamin D induced hypercalcemia. So what it is? It is probably due to something else, other miscellaneous reasons. Sir, what are they? Sir, they could be drugs. They could be thyrotoxicosis. They could be vitamin A toxicity. All of which cause increased bony resorption and cause hypercalcemia. Sir, if I have a very, very special situation, which is very common, let me tell you, if there is low 25 hydroxy vitamin D, but high 125 hydroxy vitamin D. Please try to understand this scenario. So there is less of calcidiol but more of calcitriol. So I know that something is there which is converting all the diol into triol, but it is probably not the kidneys. It is an ectopic production, and that, my dear, is the answer of granulomatous disease. Granulomatous disorder. Like the most common of which is sarcoidosis. And here also lies the answer. Why sarcoidosis has hypercalcemia, sir? Because there is production of 1-alpha hydroxylase enzyme by the macrophage in the granuloma. So you have an ectopic production of 1-alpha hydroxylase. You have an ectopic production of 1-alpha hydroxylase by the macrophages in the granuloma. Mehak Mundra, yes. Why are you mixing concepts, beta? Did I say a patient having low normal GFR can't be CKD? I only told you this yesterday. What I'm saying right now, understand that, okay? So basically, this is how you evaluate hypercalcemia. In your right wing, you have got PTH to be low. So if PTH is low, either PTH-RP is the culprit or vitamin D is the culprit. How vitamin D can be the culprit, that I have clearly enumerated. Is it clear? So granuloma, which causes ectopic production of 1-alpha hydroxylase by the macrophage, can cause calcidiol to calcitriol conversion and can cause hypercalcemia. Coming to the left, now this patient has a PTH which is normal or high. What is your next task? Your next task is to understand what is my urinary calcium. What is my urinary calcium? Sir, if my urinary calcium is low, or sir, my urinary calcium is high. Sir, if my urinary calcium is high, I know of very good disorder which could be primary hyperparathyroidism. It could be tertiary hyperparathyroidism, or it could be lithium therapy. Sir, if the urinary calcium is low, I know that there is only one disorder. It means that which is causing hypocalciuric hypercalcemia. I hope you are remembered of a disorder, and you are correct. That disorder is known as familial hypocalciuric hypercalcemia, which is known as FHH, And I hope this is clear to you. So this is the complete algorithm of hypercalcemia. So I repeat, in PTHRP is parathormone related peptide. Parathormone related peptide. Clear? So I am repeating, the first step is to measure serum parathormone. If the parathormone is high or normal, check for urinary calcium. Sir, if the urinary calcium is also high, it means that the patient is having hypercalciuria, and that is due to either primary hyperparathyroidism or tertiary, which I taught you in CKD when it happens, when the gland becomes autonomous and it says, no, I will no longer dance to the tunes of calcium and phosphate. I will go on producing parathyroid hormone on myself. I hope you remember that. That is tertiary hyperparathyroidism. Lithium, as you see, is a drug. Lithium, let me tell you how lithium causes this. Lithium, actually, chronic lithium therapy, when you take lithium for a long time, lithium causes parathyroid adenoma. And parathyroid adenoma causes increased PTH secretion, and that causes increased serum calcium. So it is basically through the parathyroid adenoma that lithium causes hypercalcemia. I am repeating, hypercalcemia in lithium is caused by parathyroid adenoma. Clear? So this is how you evaluate hypercalcemia. I am just repeating it in a gist again. Check for PTH if the PTH is high or PTH is low. If the PTH is low, check for PTHRP, because immediately think of cancers. Why do you think of cancers? I will tell you. Why do you think of cancers? I will tell you. So PTHRP is high. You know it is a hypercalcemia due to cancers. Sir, if PTHRP is also not high, then you probably think, oh my god, this could be vitamin D. You check vitamin D, you check both vitamin calcidiol, calcitriol, and is the valency of lithium +1? I'm so sorry, I so forgot chemistry. I'm so sorry, it is +1 maybe. Okay, I'm mending my mistake. Please pardon me. So sorry. Okay. So if the I will check for both the vitamin D. Sir, if both are high, I know the Dadaji has taken lot of vitamin D and that has gone into vitamin D toxicity. Sir, if the vitamin D, only the calcidiol is high, only the calcitriol is high, calcidiol is low, then I know somebody extra has produced extra 1-alpha hydroxylase and that has done the damage. That is probably a granulomatous disorder, and the most common granulomatous disorder to cause this is sarcoidosis. Clear? The next thing, if both are low, then probably something else has done it, that is drugs, thyrotoxicosis or vitamin D intoxication. Coming to, if the urinary calcium, if the PTH was high, I will check for urinary calcium. If the urinary calcium was high, it is primary hyperparathyroidism, tertiary or lithium therapy which causes parathyroid adenoma, or if it is low, it is familial hypocalciuric hypercalcemia, which is FHH. FHH. Is it clear? Let me just also tell you a very interesting bit. I told you, there is a calcium sensing receptor on the basolateral aspect of the kidney. Do you remember the thick ascending loop of Henle? Let me just draw the diagram for you. This was your loop diuretic channel, sodium, potassium, 2-chloride. Here you have the ROMK channel. Here you have the chloride channel. And here I made a calcium sensing receptor. Do you remember this channel in the loop of Henle? This channel, if the calcium sensing receptor has a gain of function mutation or if it has a loss of function mutation. Sir, if it has a gain of function mutation, it leads to Barter's type 5. If it has a loss of function mutation, that is known as familial hypocalciuric hypercalcemia. I hope you can understand. I hope your concept is clearer now. I want you to make mathematical concepts in nephrology. Everything should be picturesque clear. I know why I made this diagram. I told you your mind thinks in figures. So whenever you read FHH, you must be reminded of that channel in that thick ascending loop of Hindley ka basolateral side, and then you will remember, acha, when it will gain, that will cause Barter type 5. When it will be lost, it will be known as familial hypocalciuric hypercalcemia. Clear? If you want to learn more about familial hypercalciuric hypercalcemia, in my YouTube channel, Dr. Vivek Goel Nephrology, I have given a short video and I have told everything about FHH. If you are interested, please go and watch it. And please subscribe to it. Is it clear? So this is about the algorithm of hypercalcemia. I hope I am absolutely clear to all of you. Yes, I have scrolled up. Clear? Very good. This is about the calcium sensing receptor ka loss and gain of mutation. Is it okay? Clear. Good. This is how you you have to treat hypomagnesemia along with hypokalemia, obviously. Now, so you have understood the algorithms of hypocalcemia and hypercalcemia. Beta, Barter was the gain of function of this, and loss of function is this. Barter was a loss of function of sodium potassium 2 chloride. Okay. How do you treat hypo and hypercalcemia? Let us quickly in a gist complete the treatment also. So if you have a hypocalcemia, if you have a hypercalcemia, sir, if you have a hypocalcemia, what will you do is you will check for cardiovascular and neuro features. Sir, if there are CVS or neuroclinical features, what do you mean by that, sir? If there is a prolonged QT interval of ventricular tachyarrhythmia or there is a Vostek sign, you will not waste any time and you will give the patient IV calcium. If the patient has no CVS or neuro features, then what will you do? You will check for serum calcium. Sir, if the serum calcium is less than 7.5 or it is more than 7.5, sir, if it is less than 7.5, you will give the patient IV calcium. If it is more than equal to 7.5, you just have to give the patient oral calcium. Is it okay? Is it okay? All of you have forgotten what I am trying to say. Barter's, if nothing is mentioned, it is the loss of function of sodium potassium 2 chloride or SLC12A1. If Barter's type 5 is mentioned, that is gain of function of calcium sensing receptor. Please go and have a look and revise your notes. Clear? This is about hypocalcemia ka treatment. Talking about hypercalcemia ka treatment. How do you treat hypercalcemia? Number one, you give the patient IV normal saline. You give the patient furosemide. You give the patient calcitonin injections. You give bisphosphonates. You can give steroids. Now, when do you give steroid to a patient of hypercalcemia? That is basically in a case of steroids are indicated in a case of granulomatous disorder because steroids inhibit the ectopic production of 1-alpha hydroxylase by the macrophages. Is it clear? And if you are asked, out of all the treatment of hypercalcemia, what is the first management that you will give to the patient? The first management is always hydration. And this has been asked in the treatment of hypercalcemia. Clear? And the last management of hypercalcemia, if nothing else works, is dialysis. Just like hyperkalemia. And what will you do? You will give a calcium-free dialysate fluid. So dialysate fluid normally contains calcium, but you will remove all the calcium. So what will happen? Across the concentration gradient, all the calcium will go from the blood to the dialysate, and your blood will be having a low calcium at the end of dialysis. Is it clear? So steroids are indicated in granulomatous disorder induced hypercalcemia, but the first thing that you will give is volume, is fluids, because to correct volume depletion, because I told you hypercalcemia very most commonly presents with polyuria because of nephrogenic diabetes insipidus. I hope I am absolutely clear. There's no scope of break here because we have already come to the fag end. Steroids is given because it inhibits the production of 1-alpha hydroxylase from the ectopic site of the granuloma from the macrophages. Clear? With this, we have completed sodium, we have completed potassium, we have completed calcium. So we have completed all the electrolytes in a lot of details, and I hope it is clear. A person, Sonal Prasad, is asking, sir, why are we using loop diuretic? Let me spend a second to quench her thirst, and let me give a second to solve her query. Let me just tell you this. And I will tell you this, don't worry, Sonal. I will tell you this. Yeah. If you do remember, this is the thick ascending loop of Henle, and this is my diagram. And I told you, just to revise, that Barter's syndrome is due to loss of function mutation of this channel, that is Barter1, Barter2 is due to ROMK, 3 is due to CLCNKB, 4 is due to Bartin, and 5 is due to calcium sensing receptor. All are loss of mutation, but calcium sensing receptor 1 is a gain of mutation. Clear? Hypernatremia, not that important, will be covered in endo also. Clear? Now, very important. What happens is, if you can see the calcium reabsorption is taking place through the claudin 19 channel from the paracellular route. Can you see that? It is the intercellular or the paracellular route from where calcium is slowly creeping from the urine into the cell and into the blood. Is it clear? Clear? So, because bisphosphonates inhibit osteoclastic resorption and they also inhibit hypercalcemia. And they are the drug of choice of hypercalcemia of malignancy. Now, just see, calcium slowly creeps in through the paracellular route from claudin 19 from the urine into the blood. But let me tell you, this is though a passive process, but this is helped by the electropositive potential difference generated by this channel. Actually, this calcium move is facilitated due to this calcium entry is helped due to the potential difference created by this channel. So it is this channel which is helping the calcium to get in. Please understand this. Now, if I inhibit this channel with a furosemide or a torsemide, what will happen? This channel, sodium potassium chloride will not get in, a positive potential difference will not be created, and calcium will not go in, and I will have hypercalciuria. And this is the mechanism why furosemide causes hypercalciuria. We had learnt in pharmacology also that furosemide has a side effect of hypercalciuria. I hope this is the reason, though I have forgotten most of my pharmacology, but I do remember what is important to me as a medicine specialist or what is important to me as a nephrologist. Clear? I hope I'm clear. Very good. So this is the reason why we give furosemide. I hope I have explained to you that also. Now, very, very important. Few people had asked me this, sir, you had told me that you had taught me two syndromes. One was Barter's, one was Gitelman's, and sir, you had taught me the method also that say Barter is Barter and Gitelman is Gitelman, and then you remember, sir, the defect in Barter lies in the thick ascending loop of Henle. Gitelman defect lies in distal convoluted tubule. So the channel defect is the loss of function of sodium SLC12A1, and this is the loss of function of SLC12A3, which is basically the sodium potassium 2 chloride, and this is the sodium chloride symport. So the defect in Barter is the loss of function mutation of SLC12A1, which is the sodium potassium 2 chloride channel, and the loss of function mutation of SLC12A3 is the defect in Gitelman syndrome. This is absolutely clear to you. So, Barter syndrome mimics which channel, which drug is the inhibitor of this channel? So, it is a furosemide loop diuretic. So, Barter syndrome mimics the action of loop diuretic, and Gitelman syndrome mimics the action of thiazide diuretic. So if Barter syndrome के patient को देखकर ऐसा लगेगा, when you will see him, you will feel as if he has been on loop diuretic since ages, and a Gitelman syndrome behaves as if he has been on thiazide diuretics in ages. So दूर से देखा तो loop diuretic लग रहा था, when you went near it, it निकला Barter syndrome. And when you दूर से देखा तो thiazide was appearing, when you went near it, it was Gitelman for thiazide for distal convoluted tubule, DCT for sodium chloride symport channel. Now, till this you know, then why am I teaching you? Sir, the clinical features of Barter and Gitelman are very similar, sir. Why, sir? If you ask me the blood pressure, if you ask me the sodium, if you ask me the potassium, and if you ask me the metabolic state, I will say, sir, BP is low or normal in both. Sodium is low, potassium is low, and metabolic is alkalosis. The reasons I have explained 1,000 times in my posts. Here also the BP is low or normal. The sodium is low, potassium is low, and you have metabolic alkalosis. So both of them have hyponatremic, hypokalemic, hypotensive, metabolic alkalosis. Both of them appear to be mirror images of each other, sir. So, sir, how will a pure Atma, a Garib Atma, a simple student like me understand the difference, sir? First of all, तो ये समझ लूं कि ये barter या gentleman, that is enough. How will I understand कि which is barter, which is gentleman, sir? They are to appearing like twins. A very, intellectual will say, go and do a genetic study. देख लो किसमें क्या म्यूटेशन है. But sir, genetic study तो तब होगा sir, I will suspect it. Sir, that will be done in very few places in the country. Very expensive, sir. Take a lot of time, sir. Tell me some shortcut. No, sir. India is a country of jugaad. Do you have any jugaad, sir? Yes, absolutely. And for this jugaad, you don't have to do much. You have to just remember the effects of thiazide and furosemide only. Yes. What, sir? Sir, you told me that there is a very important side effect of there is a very important side effect of loop diuretic, that is furosemide, that it causes hypercalciuria. So, sir, please check urinary calcium. If the urinary calcium is high, sir, I know it is butter. If the urinary calcium is low, sir, I know it is gentleman. Sir, anything else? Yes, please check serum magnesium. Sir, as most of the magnesium is absorbed through the DCT, I know when the DCT will be defective, I will have hypomagnesemia, whereas in barter, I will have normomagnesemia. So in magnesium is normal, in barter it is low in gentleman. Anything else, sir? Sir, please check. Sir, the pathophysiology of barters is such. Do not ask the mechanism, poorly understood. Before only let me tell you that urinary prostaglandin E2 are high in barter and they are low in gentleman. They are low in gentleman or they are normal. Clear? Is it clear? So, when a scientist came to know, scientists published a paper that barter has a high prostaglandin E2 in your urine. Do you know what a clinician said? A clinician like me said, it might be good for a paper for you, but that is not good for me. What is good for me is, I have taken the clinical inference from you and I have understood that if urinary prostaglandin E2 is high in the urine, can I not give something to inhibit that prostaglandin? And will that inhibition of prostaglandin not treat my disease? Yes, very good. So what do I mean? If I give the patient a prostaglandin inhibitor, which is an NSAID, and the best one is indomethacin. If I get an indomethacin and if I get a response, the patient's metabolic profile gets corrected, I know it is barter. If it is not, I know it is gentleman. Such a wonderful point. Such a beautiful point. So I know there are 4 ways to differentiate between barters and gentlemans. Number 1, urinary calcium. Number 2, serum magnesium. Number 3, urinary prostaglandin. Number 4, urinary response to prostaglandin inhibitor, that is indomethacin or NSAID. And answer is this. I hope I am absolutely clear to all of you. I hope I have made enough sense to you and you have understood the difference between barters and gentlemans. There were some similarities. The clinical feature is absolutely similar. There were some genetic dissimilarities. The site of the channel. But the 4 differences are Number 1, urinary calcium. Number 2, serum magnesium. Number 3, urinary prostaglandin. And number 4, response to indomethacin. So a simple clinician like me, what would I do? I would go check the serum magnesium and urinary calcium. But in a resource limited setting, if somebody is far off, he doesn't even have this facility. What can he do? Very simple, sir. Off the level, I'm telling you, give indomethacin to the patient. If the patient's electrolytes improve in some time, it was barter. If it does not, it was gentleman. I hope I am clear to all of you. I hope I am absolutely clear to all of you. And this is how you differentiate between the two of them. Clear? 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 Very good, very good. So with this, we have understood and we have done all the electrolytes, we have done the channelopathies also, and we have understood all the concepts in absolutely details. I think with this, we can safely say that we have learnt quite a bit of nephrology, we have learnt quite a bit of medicine. And before I bid adieu to you, just temporarily obviously, I will like to discuss a few questions with you. And why urinary calcium is low? Because beta, it is due to the effect of thiazide. Thiazide causes hypocalciuria. Go and study from pharmacology why. Let us discuss this question. A question reads, 50-year-old man has presented with dizziness, has broad complexes on ECG. Broad complexes on ECG, I hope you can recall, I had drawn a figure. His potassium is 8 millimoles. His potassium is 8 millimoles per liter. Very high hyperkalemia. What is the best first medical therapy? Which is the first best medical therapy? Please tell me. The first therapy will be, sir, injection calcium gluconate. And you know that calcium gluconate follows the rule of 10. You give 10 ml of 10% calcium gluconate over 10 minutes. Okay? This is the practical thing that you do. You write on the paper 10 ml of 10% calcium gluconate IV over 10 minutes. Do not give a very fast calcium gluconate injection because it can even cause a arrhythmia. Do not give very fast. Give it slowly over 10 minutes. So had this question been not the first, the question would have said, which therapy will reduce potassium the fastest? Then what would your answer be? If I just mold the question, if I ask you, which therapy reduces the potassium the fastest, then what will you say? Then you will say, sir, it is dextrose insulin. It is insulin dextrose infusion. Had the question been this. Is it clear? Very good. Next question, dekho. Such a big question. Such a big question. And let me tell you the trick to solve such questions. You know what? Especially if you are planning to appear for USMLE, MRCP and now the next also, that's very clinical based. So you can get a very big lengthy one-page question. JIPMER gives one-page lengthy questions. Just read the last line of the question and the options first. Which medication is least likely to reduce potassium? Now just see, you need not study the entire question only. You can say, which medicine reduces potassium, does not reduce potassium? Sir, albuterol is basically beta-2 agonist, salbutamol it reduces. Sir, glucose insulin, fastest reduces, sir. Sodium polystyrene sulfonate is the potassium binding resin, sir. It will decrease the potassium, it's a potassium chelator. Sir, calcium gluconate, you told me, it does not reduce potassium. It is only used to stabilize the myocardium. And hence, the answer is calcium gluconate. So without reading the entire big lengthy question, you can mark the answer. This is the beauty how you approach and crack a question. Clear? So now, see, lengthy question. First read the last line. The correct management would be, and the options are these. So you've understood. The options are what? Free water, saline, 3%, tolvaptan. So this is basically a question on hyponatremia. Itna you have understood. But for this, you have to read the entire question. Let me tell you the keywords. He is a 62-year-old man who has undergone a prostate surgery. So post prostate surgery, patient develops acute hyponatremia. He is confused and stuporous. So there are CNS features. The patient has received dextrose as intravenous fluid and he is euvolemic with a BP of 142/80. He weighs itna, electrolytes are itna, and sodium are 114. Serum osmolality is 230. So it's a hypotonic hyponatremia, which is a true hyponatremia. Which one will you give to treat the patient? So just see, I told you there are 3 indications of 3% normal saline. If the patient has acute symptomatic hyponatremia, the patient has severe symptomatic natremia, if the patient has less than 120, the beauty of this question is, sir, isme तीनों के तीनों हैं. कैसे sir? Number 1, there are CNS features. Number 2, after a prostate surgery, so it's an acute hyponatremia. And third, it's a severe hyponatremia less than 120. And it's a telltale question. Do not study anything, sir. The answer is 3% normal saline. Free water restriction will not work here. It will work very slow. In CNS features, in 114 sodium cannot work. If the sodium was 127 and there was no feature, then I would have thought of it. Normal saline, no chance. Tolvaptan, contraindication is acute hyponatremia. You will never give here in acute hyponatremia. So the answer, you have excluded all the options. The answer is 3% hypertonic saline. Now, this is a googly. Sir, आपने तो बोला था hypomagnesemia causes hypokalemia. The question here is, why hypomagnesemia causes hypocalcemia? Is it causes a shift of calcium into the bone? Is it inhibits secretion action of PTH? Is it causes renal calcium wasting? No, it causes renal potassium wasting. It impairs the actions of vitamin D? No, sir. The answer is because hypomagnesemia inhibits the secretion and action of PTH hormone, because parathormone, the release of parathormone and action of parathormone requires serum magnesium, and that is why the answer is 2, because magnesium is required for the secretion of parathormone from the parathyroid gland. So today you understood 2 things, sir. Hypomagnesemia will cause hypokalemia by causing renal potassium wasting by not inhibiting ROMK channel, and hypomagnesemia will cause hypoparathyroidism due to inhibition of the secretion of parathyroid gland. I hope I am clear. This was a question asked in AIMS 2018, probably 2018 November. Question is, which is not used in the acute management of hyperkalemia? Which of the following is not used in the acute management of hyperkalemia? Is it beta 2 agonist? Is it insulin? Is it calcium gluconate? Is it magnesium sulfate? Anyone? Sir, beta 2 agonist, albuterol, definitely used. Yes or no? Insulin, sir, it's the fastest drug, sir. Can't be the answer. Calcium gluconate, first drug, sir. Absolutely answer. Magnesium sulfate? Is it, sir? Sir, magnesium sulfate to we use in hypokalemia, not hyperkalemia. Answer is magnesium sulfate. Answer is magnesium sulfate. This was a question asked in AIMS November 2018. So you see, now the electrolyte questions are becoming a cake walk for you. Yes or no? If yes, give me a love wala smiley quickly. Give me a love smiley quickly. Quickly. Yes, superb, superb. Now, let us enter into a slightly dangerous territory, slightly dangerous question. Okay? Yeah. Yeah. So, the question is, a 27-year-old man came with resection of a pineal gland tumor. So I told you something to do with the brain. So just see, pineal gland tumor. Develop hyponatremia. There is weakness, dizziness. Physical examination reveals dry tongue. BP is 114/70. Pulse is 100 in supine. But when he stands, there is a BP of 100/60 with tachycardia. So you know there is a postural drop of blood pressure associated with tachycardia. So you understand that what kind of volume status is he having? Tell me. So he has a hyponatremia. And what volume status does he have? Quickly tell me. The volume status is he has hypovolemia because, sir, he has a dry tongue. He has a dry tongue. On top of that, there is a fall of blood pressure and tachycardia when he stands. So his intravascular volume is low. So if you remember the classification of hyponatremia, hypovolemic, euvolemic, hypervolemic, he falls into the category of hypovolemic. Lungs are clear, no edema, of course. Now, the sodium is 112. Potassium is fine. Creatinine is slightly high. Total protein is okay. Uric acid is okay. Urine osmolality is 700. What is the normal urine osmolality? Normal urine osmolality has a big range. It can range from 100 to 900 milliosmoles per kg. Urinary sodium is 350. I told you hypotonic hyponatremia has to be divided into on the basis of urinary sodium less than 20, more than 20. Less than 20 means extrarenal loss like burns, pancreatitis, vomiting, etc. If the loss is more than 20, then you have three causes. Number 1, diuretic. Number 2, aldosterone deficiency. And number 3, you are correct. Which is the most likely cause? Pseudo hyponatremia. Not at all. It's a true hyponatremia. Adrenal insufficiency. Aldosterone deficiency. Not likely. Not likely at all. Yes, cerebral salt wasting. The answer is cerebral salt wasting because there is excess production of brain natriuretic peptide. There is excess production of brain natriuretic peptide which has led to cerebral salt wasting. So the answer is cerebral salt wasting and the treatment will be a lot of normal saline. Is it clear? So how you have approached such a difficult question, 1 page lengthy question with keywords, I have taught you this today. Clear? Now, let's see who answers this. A 32-year-old woman with a history of psychotic illness was referred for evaluation of asymptomatic hypokalemia. The question now, and the question is, a 32-year-old woman has come to you with a history of psychotic illness and was referred for the evaluation of asymptomatic hypokalemia. On examination, the blood pressure was 103/60. This was the blood pressure. So the blood pressure was low. There was hypokalemia. There was a low on the blood pressure was on the lower side. Sodium was also on the lower side. Serum creatinine was normal. Serum magnesium was also low. Suddenly you have understood what I am trying to say. The urinary calcium is also low. So there is low urinary calcium and I think now the situation is absolutely clear to you. It is a case of hyponatremic, hypokalemic, hypotensive metabolic alkalosis, which is associated with hypomagnesemia and hypocalciuria. So the disorder cannot be Barter's, because in Barter's there would have been high urinary calcium and the magnesium would have been normal. Vomiting, of course not. Diuretic abuse, of course not. Why not diuretic abuse? Can anyone tell me? Because if it would have been a diuretic abuse, usually, again, you cannot try to differentiate between Gentleman syndrome and diuretic abuse very, very clearly, because Gentleman syndrome is also a kind of diuretic only, excess of diuretic. RCC I will not teach. RCC will be taught to you in your pathology and your urology class. Please leave something for them also. Liddle syndrome, of course, you get a hyperkalemia, but the question is, it is hypokalemia and hyponatremia, and the answer here is Gentleman syndrome. The answer is Gentleman syndrome. Let us take the last question of the day. The 16-year-old male is under investigation for a long-standing muscle weakness, polyuria and polydipsia. Muscle weakness, polyuria, polydipsia. He appeared malnourished with muscle wasting. There is no edema. His BP is normal. So we have got a status that his blood pressure is normal. The serum sodium is 125, which is low. Serum potassium is 2.2, which is low. Creatinine is almost normal. Serum magnesium is normal, which is 3 milliequivalent per liter, which is in the normal range. So you have a normal blood pressure with a hypokalemia, a hyponatremia, and a normal magnesium. You get the serum renin levels, which is beyond the normal range, it is high. You have the aldosterone level, which is again above the normal range, which is also high. So basically, any hyponatremic or hypovolemic or hypotensive condition gives rise to secondary hyperaldosteronism due to decrease in the volume and decrease in the sodium. So this is again a case of hyponatremic, hypokalemic, hypotensive alkalosis with normal magnesium giving rise to secondary hyperaldosteronism, and the answer is cannot be hypokalemic periodic paralysis, because that's a channelopathy. It gives rise to weakness. You are correct, but you do not have any other disorder of sodium, of renin and aldosterone there. In nephrogenic diabetes insipidus, you have a condition of polyuria, and there, due to polyuria, excess of free water secretion, your serum sodium is high. You have a hypernatremia in diabetes insipidus. In renal tubular acidosis, what is the difference between renal tubular acidosis? Renal tubular acidosis, yes, type 1 can be a differential, but again, in type 1 renal tubular acidosis, A, you will not have hyponatremia, and B, magnesium is not at all related to it, and there you will have metabolic acidosis, so you will have hyperchloremia, and here chloride is on the lower side. Is it clear to all of you? So it is not renal tubular acidosis, and there remains only one option, and the answer is Bartter syndrome. I hope the question solving has been fun for you, and you have clearly understood how to approach such difficult, lengthy questions and solve questions on channelopathy. I think I have made you fit enough, adaptable enough to solve any damn question of any damn entrance that can be asked to you and any topic under nephrology. I have tried to cover as much possible. I have tried to take all your requests also. Is it clear? With this, I would like to, conclude my 8 days of nephrology discussion with you. I will really miss you. I will just take 2 to 3 minutes more. I hope I have been able to make nephrology easy for you, conceptual for you. Maybe you considered it very, very theoretical before, but I have tried to do this for you. I have tried to, take an extra class for you just to do this electrolytes. I could have completed my session yesterday only, but I wanted to do this also. I will keep posting relevant updates on the Facebook club page. You can definitely, follow my updates, and you will get all my updates there. And before I end, I would like to conclude my session with again a very, very favorite Hindi song of mine. That too, the last stanza of this song, and I would just like to read these lines for you. Beautiful lines written by the lyricist. Okay, and it reads: दांत दांत से काट ले बिजली तार, चबा ले तांबे की छनकार, फूंक दे खुद को ज्वाला ज्वाला, बिन खुद जले न होए उजाला, लपट है आग मिल्खा, आग मिल्खा, आग मिल्खा, अब तू भाग मिल्खा, अब तू भाग मिल्खा. So this basically says that unless and until you yourself burn, there will not be light surrounding you. So if you want light around you, please ready to burn. It is said in Hindi that bina tape you do not get kundan, which is the purest form of gold. So if you be the purest form of gold, you have to do tapasya. You have to burn yourself, and you don't mean literally burning, literally tapasya. What you are doing right now, that you're sitting at your home, is not going outside, be cut off from the world, studying. This itself is a modern tapasya. And I would just like to, or like you all, to take these 3 lines home with you and for life with you. That फूंक दे खुद को ज्वाला ज्वाला, burn, like give yourself to the task that you have at hand, and without you yourself burning, there will not be light around you, and there is nothing that can stop you. Nothing that can stop you. Is it clear? I am absolutely delighted to be discussing this with you, and again I would like to conclude with a very, very famous, with a very favorite शायरी of mine. It says that परिंदों को मंजिल मिलेगी यकीनन, ये फैले हुए उनके पर बोलते हैं, अक्सर वो लोग खामोश रहते हैं जमाने में जिनके हुनर बोलते हैं. So this is for those who have been criticized in life often, and they have not been able to answer those critics. Let me tell you, do not speak by your words. Let your actions speak. So if you are a parinda, just spread your wings. You might not be able to soar the highest today. You might not be the highest flyer today, but trust me, जिन लोगों के हुनर बोलते हैं वो लोग अक्सर खामोश रहते हैं. Do not speak anything. Just be mum, be very, very diligent and committed to your work, because ultimately everything will fade away. The color, the face, the beauty, the handsomeness, everything will fade away, and nothing else matters if you are good at your work. And if you are not good at your work, you might have 1 lakh other things, and all those lakh things will not matter. So be good at your work. Try to be a good human being, because unless and until you are a good person, nothing else matters. What are we? Great scientists like Wegener and Church-Strauss were deprived of their honor. Wegener's granulomatosis has now been termed as granulomatosis polyangiitis. Why? Because it was found out that Wegener was a Nazi. He used to conduct inhumane experiments on the prisoners of war. So the lesson to be learnt here is that unless you are a good person, forget a good doctor, you are not only a good human being. So to be a good doctor, first be a good human being. Treat everyone with compassion, have a lot of mercy. Rise as much as you want in the sky, but always keep your feet grounded. Love your parents, love your friends, live your life. Forgive easily, breathe deeply. This is also a movie dialogue probably. And nothing can stop you. Nothing can stop you. And I am always there for all of you. Anywhere. Yes, I love you all. And I I am always there for you. Any medicine doubt beyond nephrology, I usually teach nephrology, rheumatology, other subjects also. But still, if you have, I will read it up and tell you. I mean, I might not know everything, but I am there with you. All right. So thank you very much. If there is any mistake, please forgive me. I held you back sometimes. Please forgive me for that. And you do know all my social media accounts. My email ID is drvivekgoyal89@gmail.com. On Facebook, you can find me by the name of Vivek Goyal. You can add me there. In my Facebook club posts are by this hashtag Vivek Medicine Goyal. This is the hashtag, and there is a page that I have that is Love for Medicine. I request you, all of you, to please join this page. I'll be very happy, and I have started a new endeavor, which is a YouTube channel that goes by the name Dr. Vivek Goyal Nephrology. Please subscribe to this channel also. You will be getting many videos. And the last task of the day, if you have really liked my class, my last request would be to you to please take a selfie of yourself, and beneath that write a quotation that I have taught you, that I have discussed with you, that a song that I have discussed with you. Write a quotation, and on the photograph write your name and your center, your city. So if I were you, I would give my photograph, I would write Dr. Anurag Bansal, Ahmedabad, and the saying or the quotation that we have discussed, or the motivational teaching that we have discussed. I shall be eagerly waiting to see your photographs. Thousands of photographs I want to see on the Facebook club. Please give me that. I'll be really very happy and indebted, and that shall be the thank you, or the Guru Dakshina, you might call it, from your side, to tell me that you have loved my teaching. Thank you very much.